Good evening, viewers. Hope all of you are doing truly well. We are here today celebrating the World Diabetes Day on this beautiful Sunday evening. And it is our proud privilege to be with a great faculty. But before that, just wanted to present some facts that 463 million adults, 1 in 11, were living with diabetes in 2019. The number is expected to rise to 578 million by 2030. 1 in 2 adults with diabetes remained undiagnosed, 232 million, and majority have type 2 diabetes. Two-thirds of people with diabetes live in urban areas and three-quarters are of working age. 1 in 5 people with diabetes, 136 million, are above 65 years old. 1 in 6 live births are affected by high blood glucose in pregnancy. Diabetes caused 4.2 million deaths in 2019. So today, we have 4 stalwart diabetologists from one of the most modern cities of the world, which is the financial capital of India, Mumbai. These 4 are relentlessly working hard on advances in diabetes across the globe and are spreading more and more awareness while treating lakhs of patients, those affording and non-affording, with diligence. Today, as we are highly honored by their presence on the eve of the World Diabetes Day, I would like to introduce these diabetes icons to you. Dr. Anil BHORASKAR, MD, FRCP, London, consultant diabetologist, Raheja Hospitals, Asian Heart Institute and Asian Cancer Institute, Mumbai. Dr. Vijay Panikar, MD, DNB, FCPS, consultant, Department of Endocrinology, Diabetes and Metabolism, Lilavati Hospital, Panikar Specialty Center, again, Mumbai. Dr. Mangesh, MD Medicine, FRCP London, FRCP Ireland, FRCP Glasgow, FRCP Edinburgh, FACP, FICP, FGSI, FDI, Diploma in Advanced Diabetology, consultant physician, Shilpa Medical Research Center, Umrao Hospital, Asian Heart Institute, Mumbai, and Dr. MANOJ, MBBS, Diploma Diabetology, F.RSSDI, FRCP, Lina Diabetes Care, and Mumbai Diabetes Research Center, Asian Heart Institute, Bharatiya Arogya Nidhi, and PSES MG Hospital. It is absolutely a proud privilege to be with this great star-studded faculty today, and more than that, their great work. Welcome to you all, Dr. Panikar, Dr. TIWASKAR, Dr. CHAWLA, and Dr. Anil BHORASKAR. So if you can switch your video on, we'll be able to see you as well. It's a proud pleasure to be with you evening. And honestly, I really want to get to the topic because a lot has to be covered. But if you all would want to say a few words to begin the program with. And Dr. BHORASKAR, you could say a few words to the viewers and then we could actually start off.
Yeah, thanks, Rajesh. I'm equally eager to listen to all my colleagues and my friends and my students. The reason why I chose this program is to take out the misunderstanding in the minds of people about insulin and insulin therapy. And on occasion of World Diabetes Day, I thought there is an opportunity for us to talk Man Ki Baat, and all faculty that I have chosen. Vijay to is my childhood friend, and Manoj is my student, and so is Dr. TIWASKAR. So I had no hesitation to select this faculty because they are all expert in their respective fields and they are a huge experience and they are very practical. That is very
Yeah.
important. The practical tips that we are going to get from these people
Yes.
is phenomenal. So let's start with the job. And
Yes.
I think
Yes.
who is the first, what is the thing?
Well,
How the
the first question really was to you because you have so many years of deep experience working with one of the most leading diabetes hospitals of India, that is a Raheja Fortis Hospital. You've been doing so much of relentless work. We actually wanted to know your views. Also, as you know, you've been a part of the the International Diabetes Federation. We actually wanted your views to how the changing landscape of diabetes that you have seen, in our country and world over across so many years of your practice.
yeah, Rajesh, you know what I could do? I would request you to be very brief with your question.
Yes,
The question should not appear to be more than the answer. So I'll start thing. The scenario has changed. Let us face it.
yes,
I started my diabetes career 40 years back, sitting in Bhandarkar's OPD at KM Hospital. We had no problem in treating patients. We had three drugs. We had metformin. Fenformin was bad drug. Metformin, then dibinase, that is chlorpropamide, and Restinol. And the matter was simple. So we could either give half a tablet of dibinase and one tablet of metformin, and we would manipulate with that. And those people who would not come under control, we'll give them insulin. Insulin was very simple: soluble insulin, plain, and lente. But the lente had so many impurities, but people were managing diabetes very well, and our morbidity related to diabetes was not as much as what we have today. So the changing scenario has definitely given you a larger number of diabetes to treat with a still bigger menu for a diabetologist to remember. Now we are drugs acting at 12 level, dirty dozen, and we have to have a choice. It's like a big a la carte menu. When I went for a wedding anniversary, my wife said we'll go to a fancy restaurant, and the menu ran into some 54 pages. It was almost like reading a book of Harrison. So we kept it quietly and went to an Udpi restaurant and celebrated our wedding anniversary. So now practicing diabetes has become very difficult because of so many drugs acting at so many levels, and very there is a therapeutic rationale that you use SGLT2 inhibitor, you use DPP4 inhibitor, you use various types of insulin, you look analogs. So I think a choice has increased, but the morbidity has not become less. The number of cases that we see today due to cardiac failure and kidney failure, and therefore the cardio diabeto nephro is a big syndrome, and all of us are now facing problems with vertical transmission of this bloody disease in many organs, and management of the diabetes becomes so important that the complication rates increase the morbidity and suffering of the patient. So this is a changing scenario. In last 10 years this has become worse. I'm sure Panikar will agree with me. The number of cases of heart and kidney that we are seeing in last 10 years are just phenomenal. So let's hear from these people what are their views on this.
so
So I
also
think the next question should go to
yes, Dr. Panikar really,
sir.
because his practice is as as big it is, as long it is. He's actually the organizing chairman of one of the coveted Research Society for Studies of Diabetes in India. So chronologically, the next question really is, Dr. Boraskar told us about the entire scenario until now, but today we're experiencing COVID. So, if you could describe the bi-directional relationship between COVID and diabetes to us.
Sir, unmute, sir. Unmute. Sir, unmute kara.
I would just like to add to what Dr.
Yes.
Boraskar so succinctly put it, that one is the number of diabetics has increased. Second is people are living longer. The longevity of life today for an average Indian is about 70 years. 40 years ago, it was about 55 years. So the longer you live, you are going to see more complications. And that is exactly what is happening here. And like he pointed out, we have got a lot of drugs, wonderful drugs, which used judiciously can do a lot of things. Coming to your question on COVID and diabetes, I think it is well known and quite publicized that those who have comorbidities like diabetes, hypertension, heart disease, kidney problem have worst outcomes when they get COVID. But let's get one thing very clear. Being a diabetic does not mean that he has a greater chance of getting COVID. It's a very simple thing. The coronavirus enters through your nose and mouth. If that is well covered, there is no issue there. And hand sanitization, because you tend to hold your nose and mouth reflexly many times. So being a diabetic does not mean that you have a greater chance of getting an infection. The chance of getting an infection for a diabetic and a non-diabetic is the same. But once a diabetic gets the infection, then the chances of complications are much higher in a diabetic. But there again, if his blood glucose is well controlled, his other comorbidities are well controlled, the outcome is fairly decent. It is not something that being a diabetic and having COVID is the end of the story. No way. So good glycemic control in a COVID patient, the outcome is as good as a non-diabetic. So the bottom line is here is a good diabetes control is the key.
Well, that was a much awaited answer, and that the fact that you've cleared so many myths for the viewers here to hear, and it's so much of fear against that. This wisdom really will help us deal with the fear. Having said that, I think also the next question, which goes to Dr. Mangesh Tiwaskar, and the reason why I'm actually mentioning the associations and your work is so that people listening to us understand that these views are coming from you, sir, who has been the honorary secretary of the Association of Physicians of India, again a very coveted organization of physicians of India, and you've been there as an honorary secretary for 2 terms. The question really, if you can actually, one more, important question is that the metabolic syndrome and how type 2 diabetes is the most critical disease component of this metabolic syndrome. If you could explain that in simpler words for us and the viewers.
Yeah, thank you, Rajeshri, for that question. Good evening, everybody. And we are on the eve of birth anniversary of one of the most celebrated, one of the most appreciated Marathi. I would say, I'll not say him as a literist. He is the breath of me and Boraskar sir. He's Pula Deshpande. So, sir, Boraskar sir, from you as well. Greetings to Pula sir today. And we are on the
101st anniversary.
101st anniversary today, yes. So, with respects to all of him, as Boraskar sir is our Pula Deshpande in medical fraternity. And that's the reason. And talking about metabolic syndrome, yes, of course. Even though I always had a feeling that it is little overdiagnosed, but still, it's a terror within the terror. It's a pandemic of 21st century and has got a clear association with not only diabetes, but hypertension. Most importantly, it's the atherogenic lipids, which are probably the most biggest culprits in this entire milieu of metabolic syndrome, which ultimately leads to increase in the possibility of thrombosis, and the thrombogenicity goes up, either by maybe because of the increased inflammatory markers going up, or causing a higher atherosclerotic dyslipidemias which have been there along with obesity. So a concept which has been laid down far long back in 1923, but actually was for the first time talked in 1988 Chicago ADA by Dr. Jerry Raven, and that time he used the term metabolic syndrome for the first time, and has got a primary 4 components along with abdominal obesity. There is an insulin resistance, there is a hypertension, and there is a thrombogenic dyslipidemia, what we call it as, which makes actually, and then you can keep on adding the list like acanthosis nigricans, or increase in the inflammatory markers, or the vascular smooth muscle proliferation, increase in the carotid intima thickness, and all those things. But at least if you have got abdominal obesity plus 2 of the other characters, then you are likely to be called or to be labeled as a person who is having a metabolic syndrome. And the problem with metabolic syndrome is this, that it has been clearly proved by multiple studies that it has got a higher association as far as the outcomes of the diabetes are concerned. So, or any vascular disease are concerned. So it has got, so metabolic syndrome and blood vessels, they actually work as the war grounds for all the cardiovascular renal events.
Sure. This is a question. If anyone else also wants to make any inputs or comments, please go ahead.
Yeah, I think Rajeshri, he has summarized the metabolic syndrome in a very nice way. There's no need to add anything. Only thing I would say that practically every single disease of the 20th century in a urban population of Bombay can be grouped together in metabolic syndrome.
Metabolic syndrome, yes.
it came practically everything like polycystic ovarian disease, hirsutism, dementia, early dementia, Alzheimer's disease, all could be an expression of a sick gene expressed by negative environmental factors. And the negative environmental factor is all the rubbish that you people eat throughout the day and throughout the childhood, which has played this big penalty to the advancing society. People have forgotten the virtues of home food. And cola, we have been ruled earlier by colonization. Now today, this is Coca-Colonization. Energy dense drinks, chips. This is a regular diet of the children, school going. The childhood obesity is increasing enormously. You'll see waist circumference of 100 centimeters, not an unusual feature in King George students where I practice. So point is, people have stopped eating wholesome, good diet, and that is the why the metabolic syndrome with the advancing cancers, advancing atherosclerotic disease, we are seeing all that. This is just to add.
So after really understanding the changing landscape and also the metabolic syndrome, the most important aspect again is testing. So, and Dr. Manoj Chawla, you have been doing some newer work, into these into the testing right now. So we would like to know the newer advances that are there in these tests and the existing ones, and how do we really choose the right tests?
So Rajeshri, thanks for having me here, and it's a pleasure being amongst the two stalwarts in the field of diabetes. And a very good evening to everybody who is joining in from your various global platforms towards this World Diabetes Day program. So actually, the question that you asked me, I thought I didn't hear it right. But funnily enough, I wasn't sure whether you're asking me about tasting or testing, and such has been the evolution of monitoring diabetes, that it all started with tasting of urine to actually figure out how sweet the urine is, to measure the content of sugar in the urine, or to understand that today to the more modern means of monitoring diabetes, which has moved from the use of self-monitoring of blood glucose to the point-of-care devices which are there today in most clinics for measurement of HbA1c, to the current usage of continuous glucose monitoring. So today we are entering an era in the field of diabetes, even in India, where most patients would be able to measure their sugars on an almost continuous basis by the use of technology, by the use of real-time continuous glucose monitoring devices, which are now getting available for direct usage, simple to use, Of course, some amount of training there required for one to understand the interpretation of these values. But that's where the evolution of monitoring has been. So we've come a long way from the times that it was only urine tasting to urine testing to use of strips, and then today more continuous glucose monitoring and more means of uh, non-interventional or means of testing or means of looking at sugars which are going to be simpler. So of course there is a lot more work being done through the lens fluid or the presence of lens, the saliva, the tear fluid, and of course also the implantable sensors, which again have been approved in the US and EU and probably should be entering the Indian market as well in the next 6 months. And these are going to be long-term implantable sensors which allow us to measure sugars. So there has been this evolution, as everyone here would agree that when we talk about managing diabetes, one of the strongest messages to the population out there, which is people with diabetes or their families or friends or caretakers, is diabetes is one such disease that the more you monitor or the more you measure, that is the only way you're going to figure out how he or she is doing. And that is one aspect which is going to lead to better outcomes, not only in the metabolic parameters, but also in the quality of life of that individual.
That's very crisp and perfect to understand. But Dr. Panikar, also from your wisdom, really, your extensive experience, would you like to comment on it as well? So you'll have to unmute yourself. You'll have to unmute yourself, sir.
Sir, unmute kara.
Unmute
Sir,
yourself.
unmute kara. Unmute kara. Unmute kara.
Manoj has very nicely put it that the more you test, the more you know how well or how bad your blood glucose is, and you can take corrective steps. Unfortunately, what happens with many of the patients is they are told to do the test, they will write it and keep for a month and come to the doctor with that list. That is of no use. If the sugars are fine, yes, no problem. But if they are not fine, you're testing so that you can take action to correct it. And this has to go across to the people. So what Dr. Manoj said is perfect.
I'll just want to add here, actually, that one of the biggest limitations in managing diabetes today is the other extreme of it, which is hypoglycemia. So often an
Yes.
underlooked or overlooked aspect. And I think we all are doing a bit to increase awareness about education and understanding hypoglycemia. And which is why, as you can see, my virtual background,
Yes.
I've right now kept it as World
Yes.
Hypoglycemia Awareness Day, and we are appealing to various associations. This, of course, has been an initiative of our United Diabetes Forum to recognize 20th November as World Hypoglycemia Awareness Day. The reason this particular day, which is coming now in a few days' time, was because this is the birthday of Dr. James Collip, who was one of the co-discoverers of insulin. And just an anecdotal thing here that as to why Dr. James Collip, because of course he was one of the large unsung heroes along with Banting and Best, who got the Nobel Prize. They shared it with these colleagues. But it was James Collip who, for the first time, described the phenomenon of hypoglycemia. So during their early experiment of the extract from the pancreas, when they injected that into a rabbit, the rabbit went into convulsion. So because of excess insulin injected, the rabbit went into convulsion because of hypoglycemia. And that experiment, that first demonstration of low sugars, goes to the credit of Dr. James Collip. So which is where we thought it would be right to have his birthday to spread the message about hypoglycemia awareness and an appeal to all to take this up and be more aware about low sugars. As much as we try to manage high sugars, it's important to avoid low sugars.
So I think as we've discussed the core thing, which is lifestyle, of course, which Dr. Boraskar mentioned, Dr. Chawla, if you could also, throw light on something which is at the core, that is the organ, that is the pancreas. If you could explain the role of the pancreas in diabetes in real simple words for us to understand, because a lot of people out there do not really know or understand about it.
Okay, so I'll try and say it in the most simplest of words, that in the body, in the abdomen, there is an organ called pancreas, also called swadupin, the words that I've often learned from Dr. Boraskar's description over the years for pancreas. So this pancreas or swallowpin is responsible for secretion of insulin. So pancreas has two large functions, one where it supports the digestion of food by secretion of digestive juices, and second is the endocrine function by release of various hormones. One of them is insulin. Now, every food that we eat in our body gets converted into glucose. That conversion of glucose into energy is done by insulin. So insulin is an important hormone. Now, when one develops diabetes, it's essentially because of two reasons: that the insulin which is secreted by the pancreas is either not functioning well or is not sufficiently released. So when I say not functioning well, it is attributed to what is called as insulin resistance. That means there is resistance to the action of insulin. The insulin, in some simple words, can be said to be ineffective or not working as well. And also, the amount of insulin which is being released by the pancreas increases gradually over the years in the pre-diabetic time. But a day comes when the pancreas says, look here, I can't give you more. I have tried to give more and more insulin over the years and try and keep your sugars under control. But today I can't give you any more insulin. I'm completely tired out. And that is the day the individual develops clinical diabetes and the sugars tend to rise. So pancreas is absolutely central to diabetes in terms of poor insulin quality and less insulin amount being secreted.
Very nicely put, Manoj. I'm so happy that you have not forgotten your physiology and you are so precise and clear. Only thing I would like to add three or four features which are not latest, but I'm talking about insulin resistance. Now, insulin resistance is a phenomena where the receptors are post-receptor pathways. There is some problem. When the insulin reaches the cell wall, it has to go inside the cell and act on the insulin receptor. Now, either the defect is in the number of receptors or the post-receptor messengers are affected and the action of the insulin is incomplete. And that is ethnically, Indians are insulin resistant. And one of the reasons why they are ethnically insulin resistant, that Indians have a propensity to store visceral fat in the abdomen as against the Caucasians. The Caucasians may weigh, the BMI may be 30, but their waist circumference is less than 100 centimeters. While Indians with a BMI of 21 can have a waist circumference of more than 95 centimeters. So genetically, we are designed for two things. There is an enhanced apoptosis. What is apoptosis? It's a programmed death of a cell. Now, apoptosis of a pancreatic cells will cause insulinopenia. The number of pancreatic cells which are there when you are born, over a period of time, this apoptosis is known as programmed death of the cell is enhanced genetically in Indian phenotypes. And that's why our pancreatic cells get exhausted, they get depleted, and we have not only initially hyperinsulinemia, later on we are insulinopenic, and then the insulin becomes ineffective. It does not act on the target properly. The targets are muscles and fat and liver, where the failure for the insulin to act to produce insulin resistance, that is a sum total. What I've just refined it, what Dr. Chawla very lucidly said this, but I thought these are the 3 points which are important.
So that was really like precise as well as very deep understanding for us as in the pancreas role really. But as we know, it also secretes the digestive enzymes, and so that's why digestion is seen to be critical. So, Dr. Tiwaskar, how important is the digestive health for the health of the pancreas and diabetes control? Is there any correlation or a link out there?
Yeah, okay. As as we mostly label diabetes to be what we call it as an endocrine function of the pancreas, where the secretions are directly poured into the blood and they don't have any ducts to carry. Pancreas also a huge major function of what we call it as an exocrine function, where it actually has got a job of digesting the food, and especially the food that usually pancreatic juices they digest are usually fats, carbohydrates, and proteins. They are very powerful enzymes which are secreted, and they are secreted in the intestines at the arrival of the food, and that's how the whole system works. So as we know that, as Dr. Manoj has really pointed out very precisely about the endocrine function of the pancreas, exocrine pancreatic function is also equally important for a better metabolism, in a good metabolism. And if you have got a deficiency, and that is the reason why when somebody gets a infection of the pancreas, or a swelling of the pancreas, what we call it as popularly pancreatitis, because of the various reasons that you have, there are not only the endocrine problems, related problems of the to the patients, but also they get the digestion related problems as well, and especially the digestion of the fats, the digestion of the proteins, the digestion of the carbohydrates, it gets disturbed, and the whole metabolism can get disturbed. So there is a definite link of the exocrine health of the pancreas as well as the endocrine health of the pancreas.
Actually, at this breath, I would like to ask Vijay to throw light on two more axes that we have found out, particularly use of these novel drugs, SGLT2 inhibitors and DP4 inhibitor. One is the incretin axis, which is a new concept, and I think he is the right person to elaborately tell us the role of incretin axis, as also what happens to SGLT2 inhibitors, how do they act and actually bring about relief, and role of glucagon in management of diabetes. Vijay.
It's a very long and complicated question, Anil.
It's suitable for you because you will make it very simple.
See, we have been discussing about the pancreas, the endocrine section of the pancreas. Insulin is the main, which comes from the beta cells. There is another hormone called glucagon, which comes from the alpha cells. What insulin does is it lowers the sugar. What glucagon does it increases the sugar. In simple terms, how it does, we will not go into it. This is the two hormones which work against each other. Unfortunately, in diabetes, what happens is insulin is low and this glucagon is up. So insulin being low, there is more sugar. Glucagon being high, there is more sugar being produced by the body. So overall, the blood glucose is high. The DPP4 inhibitors, there is a substance known as the incretins, GLP, which is secreted from our intestines. And what does this GLP do? It stimulates insulin release. So more insulin is released, the sugar can come down. And simultaneously, it suppresses the glucagon so that the excess glucose being produced by glucagon is suppressed. That is in simple terms how a DPP4 inhibitor would work, or a GLP-1 analog would work. As far as the SGLT2 inhibitors, which Dr. Anil mentioned, it's a very simple drug. What it does is it blocks these receptors in the kidney, which are responsible for reabsorption of glucose, and it prevents the reabsorption of glucose. So there is an excess excretion of glucose in the urine. So with that excess excretion of glucose, the blood glucose tends to come down. Because glucose is going out, that means calories are going out. So the patient tends to lose weight. And because glucose and water is going out, it has a beneficial effect on the kidney. It has a beneficial effect on the heart. So that is where these two molecules, in very simple terms, are working. So they are good new molecules to treat type 2 diabetes with less chance of hypoglycemia. Since Manoj is so 20th, he is going to celebrate the Hypoglycemia Awareness Week. These two drugs, the chances of hypoglycemia are minimum if they are used by themselves. So that would be in a nutshell. Anil, I hope you are satisfied.
Absolutely. No wonder you are rated as #1 teacher in diabetology, because a very complicated affair, you have made it so simple that even an idiot will understand it. But the point is, the usage of this drug has been unfortunately promoted by the companies to the people who don't know basics of diabetology, but they are only chasing the weight loss. So what are the targets of this new pharma company who are selling SGLT2 inhibitors? not diabetologist, cardiologist. The cardiologist, you'll see many cardiologists, the first prescription is SGLT2 inhibitor because the most rewarding aspect about this drug, which has got multiple action, although it acts through the ketones and it actually initially drops the EGFR, but it causes volume depletion and 5 to 6 kilos of weight loss that all the secretagogues like sulfonylureas, insulin, the patient gain weight and they gain weight at the abdominal side. This is an advantage of these two drugs, and that is why they will definitely find the place in a prescription of every diabetic because of the beneficial effects. Very nicely put, Vijay. Yeah, thanks.
Well, then to the extension, actually, Dr. Panikar, we also wanted to know because almost more than 4 decades of your practice, you've seen so many molecules come, go, stay. If you could give us a snapshot of your insights on this entire topic, really, of the diabetic drugs that are there in the market.
See, like Anil said right at the beginning, Anil and me, we have actually seen the evolution of diabetes in terms of understanding the pathophysiology, in terms of newer drugs, the effect on different pathophysiological mechanisms. And today we have got a host of drugs. In fact, we have got 6 oral drugs and 2 injectable drugs. And any good diabetologist can use these drugs very judiciously. And I think all your diabetic patients can be very well controlled. And in the future, I'm sure there would be many more such new molecules with novel mechanism of actions, and all of them can be used very synergistically, one helping the other to give you a good glycemic control and a long-lasting control. And many a times, if you don't use the 2 molecules, that is sulfonylurea and insulin, they're the only ones which should cause hypoglycemia. So that part which Manoj is so worried about will be taken care of.
Rajesh, I must add here, very nicely put by Vijay and Manoj both. The fear of the treatment is bigger than the treatment. The people who have had an episode of hypoglycemia in their family, they are shattered. One hypoglycemic convulsion in a family deters the patient from coming to that particular doctor or even touching that insulin. Now, this can be prevented, as very rightly said. Manoj is a master of technology. That frequent monitor and monitoring right. And now he is coming out, I'm sure, will non-invasive glucose testing, which is a key. But I think I will ask Dr. Tiwaskar.
Yes.
In a person who has had episodes of hypoglycemia, how do you educate these people? Because you are practicing in an area which is predominantly in the North Bombay, and the people are resistant to any educative sessions. And you have such a large practice, you see more than 100 patients every day. How do you train them against preventions of hypoglycemia, particularly if they are using insulin? What are your messengers? What are your guidelines? How do you do your guidelines?
Yeah, thank you, sir, for that question. And it's a very practical and a very common thing that we encounter is, as sir has rightly said, and that there is a resistance to even education as well. And people are not willing to accept the change at all. So, but one of the best ways that I probably use to educate is, to have the people education camps and make them aware, just tell them in a very simpler words, as both the Stalwarts and Manoj has already spoken about, that try and so simple. And the best messenger for your work would be your patient who has had, has either been using insulins or, who has also probably, experienced in hypoglycemia. So, but one of the best messages that I can probably, tell the patients, especially as far as the hypoglycemia is concerned, is this: that yes, hypoglycemia, they do occur. There is definitely a important thing. That is a definitely important thing to be really aware about. You should be knowing about it, but don't get scared about it. the most important thing is that fear, as sir was Boraskar sir was saying, that the scare of hypoglycemia is much more than actually the hypoglycemia per se. So, don't get scared. You must know the right way of, managing yourself, what has to be done. Simple tips like, do not go on empty stomach for your exercise session or walk sessions. If you're on with insulin, probably, test before going out, have or carry some snack along with you for the easy and quick relief. Carry a diabetes card with you along with, if you are going out somewhere, that yes, I am diabetic. If I am, found behaving abnormally, or if I am found with an altered sensorium, then do this or take me to the doctor close by. And all those things can be easily done, and people accept it. And that is the reason why we run a club which is called as Association of the Isar Diabetics, and where we have got a monthly program of this kind of educational sessions for the patients. And it's the education and information that is going to help the people, best way. Yeah, Panikar sir wants to say something.
Well, yeah, Panikar.
I think what Mangesh has said is very clear. But one thing I want to add is that right in the beginning, the patient should be taught that hypoglycemia is an integral part of treatment, that there is nothing to be scared of. He should be taught why he gets hypoglycemia. There are only two reasons. Either the dose of the medicine is more or the food intake is less. These are the two common conditions which will cause. So commonest is, if he misses a meal and he has taken his injection or his tablet, he is likely to go into hypo. So explaining this to the patient right on day one, that this is the rate limiting step in treatment of diabetes, will give them the confidence of dealing with it. And they should be also taught how to deal with it, so that they are not surprised or shocked, oh my God, what has happened to me? If it is put to them perfectly, the chances of the patient going into hypo and not being able to manage it are much less. So rather than just prescribing a medicine and sending him off, no.
Absolutely.
Yeah, I think I also would like to add one
Yeah.
misunderstanding which is very commonly seen, that after a bout of hypoglycemia, many people say की साहेब आम्ही त्यांना एक चॉकलेट दिलं, आम्ही त्यांना 2 बिस्किटं दिली खायला ग्लुकोजची. The only treatment for hypoglycemia is sugar. It's a rapid acting fuel. What you do is take 2 teaspoonful of sugar, dissolve it in water and drink it. And not a chocolate. Chocolate will act after 4 hours. And at 4 hours, his blood sugar will be 300. And he'll go to some no-eye insulin giving physician. He said, "Tumhara insulin ka dose badhao." Second thing, which is also very important, that if the NPH or the night dose of insulin is high, he may go into hypoglycemia at 3 a.m. And at 3 a.m., he is not conscious enough to recognize it. But in the morning, your counter-regulatory hormones are so active, and the fasting blood sugar is found to be 200. So he goes to his doctor. He said, "My fasting is 200. So doctor is tempted to increase his night dose of NPH. That is a disaster, because one day that fellow is not going to get up. And that is the reason, whenever a person complains of a high sugar, make sure the night dose is optimized. And sometimes it's worthwhile, like the Manoj's company, you can do a 3 a.m. blood sugar. That's one great thing about the gadgets that he has fitted to the people, the CGMS. It has picked up so many nocturnal hypoglycemias, which we have missed in the past. And that's why the nocturnal hypoglycemia has to be taken into account. Now, please remember one thing. Every time for recovery from a hypoglycemia, the sugar quantity may vary. It may be 2 teaspoons, 3 teaspoons, 4. There's no fixed rule. So you have to check after giving 3 teaspoons of sugar whether the sugar has come up. Or sometimes he needs more. Yes. Or sometimes he needs a combination of a sugar and a complex carbohydrate to give him a sustained action of a glycemia.
Yes.
So this has to be taken seriously. An episode of hypoglycemia needs to be definitely studied.
Yes.
The second thing I think is very important is unaccustomed exercise.
Yes.
Now, how I came to know this, one of my guys, He has got no maid servants at home. His wife is making him jhadu pocha, and this man has been getting universally, regularly, a hypoglycemic episode at night. इसे मेरा खाना हुई है, डोज हुई है. ऐसे रात को क्या किया? हाँ, रात को सब बर्तन साफ किया. मैं पहले करता था क्या? नहीं. Now, unaccustomed exercise, you can get exertion. My lift was not working. I climbed 13 stores. All this activity profile you should write down that today after doing this, I develop hypoglycemia. Keep a logbook. That will prevent fatal hypoglycemia. I think I'll keep quiet on now.
No, sir. Sir, thanks for then completing the statement when you said Manoj's company and putting up the devices and nocturne and 3 a.m. For some reason, I thought you're talking about in Manoj's company staying awake till 3 a.m. and then checking the sugar and nocturnal hypoglycemia. So I thought it was a different trip that we are getting on to.
Manoj,
But,
your company can
but
never
absolutely,
your company is always producing hyperglycemia. Don't worry.
Yeah. So, Dr. Manoj Chawla, did you want to add anything to it?
No, I think there's a lot more to add on the hypoglycemia, but I'm sure there are other topics for you to discuss. Sorry,
Yes,
the aspect of exercise is important, and as Dr. Boroskar said, yes, we unfortunately see that. So there's a word of caution for everybody who's starting a new exercise regime, and that could come in any form, including the household work that a lot of people are doing. Essentially, when you're exercising more, your body is using up your glycogen store. So sometimes even people who check their sugars, they may actually check the sugar and find it to be normal, take their regular dose of insulin and other medications. But for those who have exercised an hour or two before the dinner period, for example, what would happen is the moment they eat and they take the same dose of insulin or medications, a lot of sugar which is present in the food gets then driven back into formation of the glycogen storage. And hence, these people would typically go into a delayed 3 or 4 hour nocturnal hypoglycemia. So, a new exercise regime always warrants more monitoring and modification of the dosage of medicines, especially insulin.
Other thing I'll just add quickly, because I have a lot of patients who complain of this and their fridges are loaded with cold drinks. And one fellow says that after drinking a 200 ml of Coca-Cola, I felt a lot better, because sure enough, Coca-Cola contains almost 13 teaspoonful of sugar. Plus it gives caffeine. So it gives you a pep up. So if somebody says, can I have a Coke? Because I don't know, I didn't get any sugar, because drinking only sugar it gives me nausea. Sure enough, you can drink a Coca-Cola bottle, or you can do a Pepsi or even an orange. But many times remember that sugar is enhanced by the ingredients in it, and the absorption is rapid with aerated drinks. Remember that. Aeration improves a quick absorption from stomach. Aerated drink will give you more quick rise of sugar than plain water. And that is why sometimes a Coke or a Pepsi or a Fanta can be of a life-saving drink. And if somebody has to take it, he can take it.
Sure. So, though we are laughing on that point, that is such a common thing that patients are observed to be doing. But also, I know I'm extending the topic of drugs really, but Dr. Tiwaskar, just as Dr. Boraskar was earlier talking about the weight loss advantage of one of the drugs, when it comes to managing diabetes complications, which are the drugs that are important? Because this is again something, which is very important, because a lot of times diabetes leads to atherosclerosis and other complications. So what would you like to add about or educate us about?
Yeah, mostly, diabetics are bound to develop complications over a period of time, sooner or later, depending on their glucose control or how they behave over a period of time. And naturally, we do have got beautiful drugs to take care of them. As Panikar sir has already been talking about this, there's one such drug which is called as pioglitazone, which is one of the best cardiovascular protective drug that we know about it. If you use them smartly and wisely, they are one of the best cardiovascular and renal protective drugs that you have in the kitty. Now we have got SGLT2 group of the drugs, which not only offer you the glucose control, but also offer you a fairly fantastic heart protection, kidney protection as a whole in toto, along with the weight loss and blood pressure control. So multi-pronged benefits of these SGLT2 group of the drugs. You have got on the other side, we have got DPP drugs, those who address that GLP-1 effect that Dr. Panikar has already alluded to. And more importantly, we do have our good old metformin, which also played a role. But in a sick situation, in a complicated situation where you are in trouble or inside the hospital, if suppose somebody is really sick and down, the only drug to be used is to be insulin, and there is no other drug which ideally should be used in a situation where there is an acute emergency or the patient is sick and is in the ICU or in the hospital.
Yeah, so I think that chronologically really brings us to the question that we're almost celebrating the 100th anniversary of the discovery of insulin, and
in fact, Rajeshri, as Manoj has alluded about Dr. Kolip's hypoglycemia, but that Kolip was the guy who actually saved Benting and Best from losing the molecule, because he was the guy, he purified, and in 2 weeks of time, everybody knows that the first injection of insulin was a failure. It did not give any effect at all, and it was Kolip who came to their rescue, and he crystallized that, he purified that insulin within 2 weeks. Now imagine, days of 1921 and 20s, where you have got limited abilities, limited resources. This guy thinking and coming out with the purification technique of our insulin, which made sugars of 500 come down to bang 130, 140 range. So imagine the credit of Kolip. Huh?
Mangesh, you must have had some brewery experience.
Yeah.
Yeah.
Yes.
Yeah.
There's another very important area. I think we all need the input from all these stalwarts.
Yes.
The most important area where we have really not paid attention is the nutritional aspect
Yes.
of management of diabetes. Now you are talking about insulin, yes. You're talking about sulfonylurea still there to stay. AGLT2 inhibitors, yes. DP4 inhibitor, alpha glucosidase inhibitor, pioglitazone. They all have helped, but what will really help properly is, if you want to overcome insulin resistance, the thing that you have to eat is a keep control on your mouth. My mom used to tell me that तोंडावर ताबा ठेवायला शिक. Both the ways. When you take out something from your mouth and take something in the mouth, keep a control. Now that is very difficult. Very difficult. I am telling you from my personal experience that to keep a taba on toned is one of the greatest achievements one can do, and that is what is maturity. But in dietary practices, India is a great country of a diversity. There is a change of diet every 40 kilometers. The curries that you get in Bombay and you go to South, and the type of sambars and chutneys, the variety is such that after 40 kilometers, the taste of food varies. So diversity is not only in languages, in culture, in practices, but it's in diet. But if you see the thali, carbohydrates, proteins, fat, mineral, Gujarati thali, Rajasthani thali, South Indian thali, Punjabi thali, the constituents are same, and that is what is known as unity in diversity. Our country, we are great people because we are united. Although there is so much of difference. Now this is a problem which has spoiled by commercial world. How it has spoiled? In chasing the phantom of cholesterol, they condemned our traditional fats like coconut, ghee, and promoted polyunsaturated fatty acid, which had tremendous amount of omega-6 fats. And the epidemic that today we are facing of diabetes, heart disease, and cancer is because of this high omega fat containing fatty acids, commercially made very successful as heart friendly oils. They are not heart friendly oil at all. There is not a single bed available in ICU in Bombay. Why do you get this epidemic of this disease? Because people are eating bhajiyas, pakoda, batade vada. Fried food has become a eating culture, and frying in wrong oil is a major source of all the evils. We have deviated from our traditional fats, and we are paying penalty for it. All of you can add your comments on my dietary practices. Dr. Panikar, to start one, our diet is identical, and when we talk on platforms like this, but the food that we eat, people should not take our photographs. Dr. Panikar.
Very well said. What I advise my patient is, whichever oil you use minimum. That is the bottom line. Because each different areas of India have different lifestyles. Like you go to the south, they are on coconut oil. You go to the north, there is tilka tail. There are so many different varieties which are ethnically and part of their culture. Don't change their lifestyle. Minimize it. I think the bottom line in management of diabetes is limit mein khao. Have everything, but see that it is limit. Don't overdo anything right, left, and center. Like I tell my patient, आलू की भाजी मत खाओ, लेकिन भाजी में आलू है तो खाओ. You know the difference. So it is the moderation which is most important.
Well, here again, I have a small experience to share because we do integrative personalized nutrition. So have you all seen any advantage because of it? If any personalized diet is offered to the patients, is there better compliance that...
You want to hear from me?
No.
I think
no is the question.
The personalized diet,
yes. In fact, yes. Only we want to listen only from you, sir.
The personalized diet written by a very attractive looking dietitian who herself looks like a dish. So this many times I had kept means I have employed two dietitians. You would write a very elaborate diet, very scientifically perfect, balancing all the nutrition and all. After spending 30 minutes with them, the patient would come back again to my chamber. साहेब हे काय ह्या बाईने काय लिहून दिलंय हे बरोबर आहे काय? तिने जे काय शब्द मला ते मुसली आणि ह्याचे कॉर्नफ्लेक्स ते आम्ही काय खात नाही. म्हटलं बरं मी त्या बाई चांगल्या आहेत ते हुशार आहे मी तुम्ही काय काय खाता? आम्ही हे खातो. व्हेरी गुड. त्यात तुम्ही तेल किती घालता? So I only modify their existing eating habits.
Yes.
But writing a prototype diet, which runs in sometimes 2 or 3 pages by very elaborate dietitians, very high profile dietitians, people come and ask me, hey, barobar hai ki nahi? So therefore, we take their advice, we take the nutritional advice from our dietitians, but the practice is, what is practice?
Yes.
Why Vijay Panikar and BHORASKAR are great practitioners? Because practice has made us perfect. Practice makes man perfect. We have learned over a period of time. I have learned from not from the textbooks. I have learned from my patients. I have learned from their relatives. So a practical diet is the one what he eats, very rightly said by Vijay, only moderation and cutting down on the oil portion.
Right. Dr. Chawla, you wanted to add something?
Yeah. No, I think jokes apart from what Dr. BHORASKAR just said, there is a lot of fact and practicality in what he's saying. So though as much as most of us today would want to have a nutritionist, dietitian on board as part of our team, it's extremely important that they, in fact, work not only as nutritionists, but also as diabetes educators. And I'm sure a lot of them who are working with us are the ones who are trained in those courses that we conduct. And I think they're extremely important, a part of the entire diabetes management team, which is goes beyond just the diet aspect, but within the diet also the evaluation of diet, the means about hand-holding for the patient. And that's where what Dr. BHORASKAR said becomes extremely important. And I see that changing now, and hopefully that trend continues. But till a few years back, I think it was the training imparted, and he's absolutely right that you would see a diet chart which may should have been individualized, was based on a one-on-one interview, but it still seemed like a printed prototype, which is talking only about the examples of muesli and stuff. So it seemed that one person created that, and in your training modules, you taught that to the new bunch of dietitians and nutritionists, and they all continue to follow the same, which doesn't make sense. So it has to be absolutely practical, asking the individual what he or she eats, and then within those aspects, modification, acceptable modification, which is based on a conversation between the nutritionist and the patient. So just as a doctor would very often talk about whether it's insulin or other therapy, the what the job that the nutritionist does is as important. But somewhere we thought in the initial part of the years that was missing. Hopefully, the changing training for a lot of newer bunch of nutritionists and dietitians is making them see that sense and be more actually genuinely individualized rather than being generic.
We've almost completed an hour, but I have a couple of important
I want
points.
to ask a question.
Mhm.
All questions to my panelist. It is very important. And without taking his name, there is a very high profile doctor who's been advising 2 meals a day in a gap of 12 hours. And he says that you can eat anything in that meal, but keep a gap of 12 hours. In some people, it has helped. They have lost 5 to 6 kilos of weight, and they swear by him. And there are many government authorities have taken him on the board. Physiologically, I have my reservations about a diabetic taking anything at the gap of 12 hours. What is your opinion, Mangesh, Vijay, and Manoj?
Yeah, I completely agree to you, sir. And to be very honest and to be very critical about it, I am absolutely one of the strongest critic of that concept. And we have seen complications with happening to the patient. And in fact, especially as far as diabetic population is concerned, in fact, it has not benefited patients over a long term. The short term benefits probably it has offered, but over the long term period, this diet probably has pushed people to develop more complications rather than giving benefits. So I absolutely go to what you are saying, that I am a very strong critic of this diet.
Vijay, what do you think?
Mm.
You must be seeing many very high profile, you practice in a very high profile patients. You must
No,
be having at least one or two patients who must be doing this. What is your opinion?
see, I will tell you.
So I'm going to
That,
interrupt here for a minute. I think because you've been explaining everything so much in simple words, if you can really explain this phenomenon in simple words, because yeah, what Dr. Boraskar is saying is this is really an alarming phenomenon which is all over the place, and people have been asking us these questions on this forum. So if you can address it in a very simple way, people can really understand the bad effects of this, if there are.
see, there are dime a dozen weight reducing programs. Every few years, you find some new fad comes in that this is the best for diet. So this is one of those fads. When it comes to a diabetic who is on medication, he has to have his spaced out meals, his breakfast, lunch, evening snack, dinner. If he's on an insulin or a sulfonylurea, if he's on drugs which do not cause hypoglycemia, then possibly he could do this as part of his weight reduction. Ultimately, what does this do? He's eating only twice in a day. We Indians are eating the whole day. We have a breakfast, we have lunch, we have a mid morning snack in the office, we have evening chai, we have dinner, and between evening chai and dinner, we'll have bhel puri and pani puri and everything. So we are eating the whole day. And Indians love that. What this guy has done is he has made it into two compartments, 12 hours apart. Now, however much you eat, how much can you eat? And that gap, so total caloric intake is going down, and that is the mechanism by which the weight loss is coming. But in a diabetic who is on a medication, it's a known. A non-diabetic could do what he wants to do. He may have one meal also. I have no issues. But there is a keto diet that you only have fats and proteins. And people lose weight. There are celebrities who have lost weight. But is that good for diabetes? No. So each food fad has its era, has its time, and it slowly dies down. So this is what I would put it here. What do you think, Mangesh?
Yeah, as a matter of fact, I would completely agree. And there cannot be any diet which can be blanketly applied to everybody. It's like a completely personal. As medications are now becoming personalized, individualized, there has to be a diet which has to be completely individualized. So you cannot apply that concept to each and every patient.
Manoj,
Everybody has it.
Manoj,
what
what's
is
your
Manoj is saying? Manoj is also a very high profile diabetologist.
No, so I think everything's been said, and I completely agree. And the last word on that has been said by everyone, including Dr. Panikar. No one diet can fit all. All these are fads. Yes, some would benefit from a keto diet. Some would benefit from a low carb diet. Some would benefit from an intermittent fasting. But extreme caution. So if patients ask us or ask me, especially the ones who are on significant amount of medications and insulin, unfortunately, we've seen a lot of them come back to us with extremely high sugars or completely deranged metabolic profile as a means of following this. So just the aspect of listening to it on a WhatsApp group or any of the social media and starting to follow. I wish things were that simple, that one kind of godman appears and gives one kind of diet that here, take this and everybody is going to be perfect. I really wish things were that simple. Unfortunately, they are not. So to everybody listening in, extreme caution. Always discuss with your physician any aspect of change that and even if you do try, and some of you may benefit, continue to monitor, because unfortunately, what we have seen is none of those benefits are long lasting, and after a few months, things just turn for the worse. So keep a watch. Those who benefit, good for them.
There's a word of caution I'll give to you as a winding point. I've seen a lot of young dietitians writing metformin to the patient. Now, please remember, dietitians are not supposed to write drugs.
Right.
The metformin is advised not by them. There is a weight loss tablet. I'm very glad they don't write AGLT2 inhibitor. So any drug that
now
you
from
take,
tomorrow, sir, after they listen to you from tomorrow, they will start.
no. I see many patients. What I feel, the drug has to be taken with the permission of your diabetologist only,
Yes.
and nobody else. Keep that in mind.
So one of our panelists, of course, has to leave a little earlier because he has another such great talk. But before he leaves, and we are also coming towards the end of our program, but before he leaves, Dr. Tiwaskar, one another point which you have been advocating to implement the concept of euthymia in diabetes care, and I know you have written papers on it, and if you could share the same, especially given the fact that depression is prevalent in diabetics, and we see diseases like Alzheimer's, Parkinson's actually worsening the quality of life of such patients. What would you like to say?
Yeah, thank you. In fact, euthymia, we had an opportunity to publish extensively on that, and we worked. Basically, the word which is, actually talks about, living happily with diabetes, and I would probably pass on this question to Dr. Panikar, sir, who definitely promotes the idea of, living with diabetes rather than suffering with diabetes, how happily somebody can live. So he always promoted that idea of how to live with diabetes, but their euthymia adds to a concept of how to live happily with diabetes, with not only accepting the disease as a whole, but you at the end of the day, you are not distressed, or you are not you are not distressed because of diabetes. So that diabetes distress phenomena is dropped away. So I'll pass on this question to Panikar, sir, and please excuse me because it's high time now. I must
Okay,
leave now.
Mangesh.
Thank you very much.
Thanks a
Thank you
lot.
very much for being
Thank
with
you
us.
very
Bye,
much.
bye, Mangesh.
Bye,
Bye-bye.
Manoj. Bye, Panikar, sir. Bye, Rajeshri. Bye, Boraskar, sir. And thank you everybody for having me on this platform. Thank you very
Okay.
much. Yeah.
We'll allow you to.
Pleasure. So, Dr. Panikar, would you want to add on the euthymia point of it? And of course, I have a couple of more questions for you. You'll have to unmute yourself.
So basically, a diabetic is quite depressed. He is quite anxious. What is my future? And all this is because he doesn't accept the fact that he is a diabetic. I think once you make him understand that this is here to stay and there is nothing to be scared about. Diabetes is a bad disease, yes. But if you respect diabetes, there is no issue. Keep your sugars under control, keep your blood pressure under control, keep your lipids under control, and you will be safe. You will sail through safely. If that message can go through and you can give those results to your patient, it is a very reassuring thing. And like I tell my patients, I don't want any of my patient telling me or telling anybody I'm suffering from diabetes. No, he should say I'm living with diabetes. There is a big difference in the perception. And that is what is the crux of the matter. Acceptance, respecting, and living happily.
Very well said. Very well put, Vijay.
Dr. Boraskar, that is another very important aspect of your practice. That is humor. So what would you like to add again?
I tell you what Vijay said, that you have to change the concept of the disease. First of all, this disease has many sufferings, and every diabetes dies every day with some or other complaints. But those complaints are sometimes they are warning signals, like a lower limb getting cramps and this lesions not healing. They are warning signals. I'm not saying that you should ignore them, but there is something known as philosophical neglect towards certain types of ailments where the drugs don't help. Neuropathy, for example, burning paresthesia, gastroparesis, gastric distension, forgetfulness. Now, forgetfulness is not a disease. It becomes a part of your training. Why we think we have made computers and I think we have become worse after these mobile phones, which you keep on registered. Formerly, I used to know at least 200 telephone numbers by heart. But I have not become forgetful. I have not become dementic. There is one concept known as denial, deprivation, and dementia, early dementia. Now, do you know one thing? That what is type 3 diabetes? Type 3 diabetes is Alzheimer's disease. And Alzheimer's disease is also, the name looks very respectable, Alzheimer's. आम्ही मराठीमध्ये खुलचट झाले, येडझावा झाले आपण. Alzheimer's is dignified. What is Alzheimer's? Is a pre-senile dementia. People diagnose Alzheimer's disease in 80-year-old man. But he's senile. He's senile. He's bound to behave in this fashion. But if you get problems at the age of 35, 40, then it is a serious matter. And in a diabetic, because of diabetes distress, you can get first phenomena denial. मेरे को है नहीं diabetes. क्योंकि डॉक्टर लोग क्या खाली फुकट मेरे को फंसाता है, ये खाए ये नहीं. Denial. Then comes a stage of depression. And you know one thing, 45% of Bombay's population, particular professionals, have subconscious depression. Many reactions which come up are because of depression. Doctors are depressed. I am depressed because Panikar and Manoj CHAWLA, they have Mercedes and Audi cars. Arey, chhodna yaar. Why do the professionals amongst themselves compare and get depressed? And there is subconscious depression. You don't accept that you are depressed, but you have your certain reactions out of depression, and depression is a very common problem in diabetes, which needs to be addressed, sometimes with counseling, sometimes with drug therapy. Then the third thing, a diabetes distress, is fanatism, food fanatics. आम्ही कधी ह्या गोष्टीला हात लावत नाही, आमच्या घरात कोणी ह्या गोष्टीला टच करत नाही, प्रसाद पण खात नाही. Idiots. These are the people who take out these fatwas on themselves. And that is again a feature of depression. So denial, depression, and subconscious memory loss is a feature of long-standing diabetes. This can be easily overcome. And the greatest guru killi is a humor. If you have a humor in your behavior, in your thinking, and you learn to look at the events in life lightly, philosophically, many of your so-called Vedana, turmoil, everything comes down with the way you look at the disease. A day you look, अरे ये मेरे को diabetes है. Look at a disease as an advantage, as a blessing in disguise than a curse. Look positively, be positive, and things look all right. Now I'm not. I think I'm already started talking like a, philosophical guru,
Guru. Yes.
which I will cut down now.
Well, a couple of questions before we wind up, because this was actually a very positive note to end the program. But one very important question, which I of course want to direct to all of you, but Dr. Panikar, if you could first share your insights, basically the precautions that the geriatric patients should take, given nephropathy can affect the kidneys, and neuropathy and diabetic foot disease. These are more serious implications of diabetes, really.
See, this neuropathy, nephropathy, foot problems can affect anybody, not only the elderly. So that is not a problem. Specific problem in the elderly, I would think, is hypoglycemia. You should not, you should not be looking at a very tight control of sugar in the elderly. Be a bit more relaxed. HbA1c of 8 is comfortable. Nothing will happen. But if they get a low sugar, that is probably bad for them. So that would be the only thing that I would be looking at. All the other complications any diabetic would have, you treat that complication as and when it is there.
Yes.
But consciously, as a treating physician, you would want to avoid hypoglycemia. And this is something which the patient and the relatives also have to be told and taught, that at this age, hypoglycemia is to be avoided.
True. So a lot of these myths, I think, Dr. Chawla, we were discussing that we should be covering this in this program as well. A lot of them we have already covered. Are there any other myths you really also want to talk about or address? We can though see Sean Connery at your background. I'm sure there's some significance.
Idea that's my tribute to the best
Yes.
Bond ever. So absolutely no doubt about it. Well, I think one of the myths is there are actually many myths, and some we have covered, and I think it'll take another hour, so we'll leave that for your next program.
Yes. Yes.
Some of the myths I think that we were speaking about, a lot of them revolve around insulin therapy, and I think we did decide to have a complete specific program on insulin at a later date. But just to clarify, very often the use of insulin for management of diabetes is essential, and very often it is used as a temporary means to overcome either the glucotoxicity or around a surgical time or during an acute crisis of high sugars. So the biggest myth surrounding insulin therapy that patients have is in general that if I take it once, I'll have to take it forever. Now, for a lot of people who have had long-standing diabetes on multiple medications not responding, when we suggest the use of insulin, they may need to take it for a long period. But for a lot of other individuals, we actually tend to use insulin therapy for a shorter duration. So one of the commonest and biggest myth is that once on insulin, then I'm stuck on it, atak gaya, abhi lifelong lena padega, which is not true. Also, there are myths surrounding medications. What does happen is very often patients would take insulin or other medications after many years of diabetes. Because the sugars have been extremely high, they start taking a little more aggressive therapy or insulin. Soon after that, on screening, because they never really have tested themselves for screen, when we screen them, we realize that these patients may have nephropathy or retinopathy. And unfortunately, there goes a correlation that, doctor started me on insulin or increased my medications and I landed up with kidney problem or I landed up with an eye issue, which is so strange, but it's an extremely common myth that people come up with and feels terrible that when you're equating the use of that medication which happened at the end of your 15-20 years of diabetes and the occurrence of complication which was related to long-standing diabetes. So complications are more directly related to your chronicity of the disease and poor control and not to medication. There are myths surrounding that if I take these medicines, and that's a question I'm sure every patient asks a lot of clinicians, ये दवाई लेने से हमारा किडनी तो नहीं खराब होता है ना, कुछ हमारा complications तो नहीं होता है. Well, so the fact is that those complications happen if you're not under control and not because of the medications. If there are any side effects of a particular medicine, the doctor would always discuss that with you. For example, chances of low sugar with insulin or with sulfonylureas, the chance of a urinary tract or a genitourinary infection with SGLT2 inhibitors, and so on and so forth. So there are multiple myths for diabetes, but importantly, if there are myths, it's the need of the hour that the patient and the family continues to have a conversation with their physician. As I said earlier today, besides the doctors, the team, when you have at a diabetes care center, which does very often have a diabetes educator as part of the team, they play extremely crucial role because in India, physicians see a lot many more people in a day. They may not be able to always do justice with time that they spend with the patient. And that's where the team comes in and having longer conversations and clarifying any of these myths. So that's important today that we continue. If there is a myth that the patient has, they should discuss and then take it from there.
I will just sum it up in three sentences. The most important point, which I always like to take, that there was a patient who asked me, I got a diabetic neuropathy, nephropathy, retinopathy, vasculopathy, dermopathy. What do you have to offer me? I said, the only thing I can offer you is sympathy. So thinking that you try to see that these conditions are avoided. Take care of them at the beginning. Don't let them increase in severity. Then the management of the complications become difficult. Detect, diagnose in early stages, everything is treatable happily, and a patient will not develop relentless complication. That is the Guru Mantra: early detection, early treatment, aggressive treatment, because it has, in a treatment of insulin, why do you give insulin early in a first stage with the HbA1c less than 7.5? There is something known as legacy effect. There is a metabolic memory. If you treat the patients early with aggressive approach, later on, even if the treatment is not so aggressive, they enjoy the same benefits of aggressive treatment given early. This is known as metabolic memory or legacy effect. And to get that, the patients have to be motivated to take their treatment early. Thank you very much. I think there should not be any more questions because we are in our time.
So we
and
were
I
at
have to thank both my very dear brothers, Vijay, and this boy is like my son. They have done a wonderful job, and they are, I mean, because of proximity and that we are so close, I never knew that they are loaded with such kind of knowledge and information and practical tips. Really big salute to them, and I'm very thankful for them to spare the lovely evening in the on Sunday. And thank you very much, Rajeshri, for giving us a platform to disseminate many misunderstanding in the society. Thank you very much.
Well, Dr. Panikar, we would also want you to put in some takeaways and concluding remarks to the program. It is always a pleasure to be with Dr. Anil Boraskar and all of you, and Dr. Chawla, of course, to be with you on this program. But any last remarks that the viewers can take away home?
We Indians, as a community, believe in miracles, believe that something can come out of the blue and cure my diabetes. And that is why we are a land of Babas, dime a dozen. Anybody can become a Baba and give any funda that they want. So the misconception that it can be cured. In fact, I'll tell you, yesterday I have seen one lady who was for 5 years never controlled. And a month back, she had come to me with treatment. She has come with a beautiful report yesterday. And I said, wow, fantastic report. I'm so happy. She tells me, डॉक्टर मेरे को एक बात बोलने का है, मैं है ना रोज रात को भिंडी काट के पानी में डाल के पी रही हूँ, उसके वजह से है ये. My God. I mean, this the concept. I said, बहुत अच्छे, ये दवा सब बंद करो, आप भिंडी का पानी पीते रहो, और मेरे को एक हफ्ते बोल. You know, this mindset has to change. I think in today's world, the allopathic medicines are the best that are available. They are tested, tried, and very safe for the patient. So let this misconception be out that it does harm or anything. No. That is the only message I.
So we conclude that program on those beautiful takeaways that you put forward, and it was an entire complete program starting from the core of where the diabetes starts, the entire scenario that you both, Dr. Panikar and Dr. Puraskar, you've seen for last 40 years. Yes, Dr. Chawla, yes, please go ahead.
No, I just want to end at mine saying that it's been a pleasure being here, especially in the company of two of my gurus. It's always a pleasure to be with them, to be with Dr. Panikar and with Dr. BHORASKAR. It's a pleasure to keep learning. I think every such interaction, there's always something for us also to learn from the rich experience that they share. So it's been a pleasure being here with them. And would just want to say, as said by Dr. Elliot Jocelyn more than a century back, that a diabetic who knows the most lives the longest. And I think that's the mantra. So kudos to you and your team for organizing these patient-centric, population-centric programs. The more the person with diabetes, they enrich themselves with knowledge about diabetes, I think that's going to help them live longer and better. So with that note, would want to sign off and
Yes.
a very good evening to everyone again.
And it's my privilege that, and I'm going to fold my hands and thank all three of you for, coming here and imparting such simple yet, deep information, education, wisdom to the viewers. And our attempt is going to be to take this program to the maximum number of people, and we will surely achieve that. I would like to also thank my backend team led by Mahesh Tarade, who actually they take care of sending this to many people. So on that note, we'll end this program with a promise that we will come back with you and more information and more that you would also like to take to the viewers and patients all across the country and the world. Thank you very much for being with us.
Thank you.
Dr. Anil Boraskar, thank you so much. Special thanks to you for helping us, get this together. And it's really were your insights how we could structure this program. Thank you so much, all of you.
Bye-bye. Good evening. Thank you.
Bye-bye.
Viewers, I leave you with this promo of RSG Energy and Nutrition. They keep relentlessly taking our program forward to many forums, many groups, and also provide us technical support for taking these education programs all over the country and all over the world.